Welcome everyone to Chapter 3 Health as Social Justice, a whole person activist approach, a social justice approach to health. This chapter is a hinge point in the course. Up to now, we've been building a shared vocabulary for whole person health communication and the models for health and disease. Starting today, we begin asking a harder question: engagement and advocacy, for whom and on whose terms? Whether your background is communication, health sciences, or nursing, the content in this chapter should relate to you. Communication students will see how message design, framing, and organizing connect to real material outcomes like life expectancy. Health sciences and nursing students will recognize the social determinants of health framework from your clinical and public health coursework, but also from chapters 1 and 2. Here, we're going to push past the awareness of SDOH, that is the social determinants of health, and into the social justice lens that explains why those determinants exist and persist, and what it means to intervene. By the end of this lecture, you should be able to define a social justice sensibility, explain intersectionality as it applies to health equity, connect SDOH to distributive justice and community empowerment, and start identifying where you personally might engage in health communication activism. Let's walk through our 4 objectives in this chapter because they build on each other sequentially. First, we'll identify social justice values and principles, and specifically how those principles reveal health inequities when you look at them through an intersectional lens, meaning through the compounding effects of race, gender, class, and other identity categories together, not separately. Second, we'll look at how social justice shows up inside medicine itself, in training, curriculum, and professional culture. Third, we'll formally connect the social justice approach to 3 frameworks you may already know in isolation: social determinants of health, distributive justice, and community empowerment. In this chapter today, we will integrate these and take a look at them as an overview as they play together in the same framework. Fourth, and this is the applied piece, we'll talk about health communication activism, and I'll ask you to start identifying issues you personally care about and other ways of translating these in engagement and advocacy in the lab side of things. This slide is a title slide, and I'm going to pause on it for a minute. It names an intellectual tradition this chapter is born out of. Engaged scholarship in communication studies is associated with scholars like Lawrence Frey and Kevin Karaji, and it refers to research that doesn't stop at describing a problem from a distance. Engaged scholars work directly with communities, apply their expertise on behalf of people who are under-resourced, and treat the researcher and practitioner and professional healthcare professional or communicator's role as inherently value-laden, not neutral. This matters to you as future practitioners, whether you go into health communication campaigns, clinical nursing, or public health research. You will constantly face a choice between a neutral, objective posture and an engaged, subjectivist, and occasionally activist posture. This chapter argues that health equity works for the latter. Let's define our central term. Karaji and Frey describe a social justice sensibility as the application of knowledge, methods, and practices on behalf of the disadvantaged specifically to intervene in unjust discourses and unjust material conditions, to make both more just, and then to document and report on those practices and their effects to multiple publics. Unpack that definition with me. It has three moving parts: knowledge and method applied on behalf of the disadvantaged. Intervention into both discourse, meaning how we talk about health and who gets blamed or credited, and material conditions, meaning actual resources, access, and outcomes. And finally, an obligation to report back to multiple audiences, not just academic ones. Fry and colleagues add that this sensibility foregrounds ethical concerns, commits to structural, not just individual, analyses of ethical problems, adopts an activist orientation, and seeks identification with others. Note the word structural. This is a recurring theme in this chapter. Health problems are not simply about individual behavior or choice. They are produced by systems. Fry, Pierce, Pollock, Arts, and Murphy define this more fully as engagement with and advocacy for those in our society who are economically, socially, politically, and culturally under-resourced. Let's break the four elements down one at a time so they are usable, not just quotable. First, it foregrounds ethical concerns. Ethics isn't an afterthought or a compliance checkbox. It's a starting point of the analysis. Second, it commits to structural analyses of ethical problems. We ask, what system produced this? Not just, what did this person do? Third, it adopts an activist orientation. The scholar or practitioner doesn't just observe, they act. Fourth, they seek identification with others, genuine solidarity, and shared meaning-making with the community, not speaking for them from a distance. For the nursing and health sciences students in my course, think about how this reframes cultural competence. For my communication students, think about how you would communicate what we know about a patient population. How will we identify with them? And how will we advocate alongside that population? Let's ground this in a concrete real-world example. The American Public Health Association's 2018 policy statement conceptualizing public health and public safety. APHA's move here was significant. They argued that safety should be understood far more broadly than law enforcement and policing. Their expanded definition of safety includes law enforcement and policing, yes, but also, this is important, affordable housing, healthcare access, healthy food choices, green space, and quality education. How does this all matter to a social justice approach to health? Because it reframes what counts as a health intervention. If safety includes housing and green space, then a housing policy or a park budget policy is a health policy. This is the structural lens in action. It moves the conversation from fix the individual to fix the conditions. Now we have a shared vocabulary. And I want to be precise about these terms because students often use them interchangeably when they shouldn't. Health equity. The principle that everyone should have a fair and just opportunity to be as healthy as possible, which requires removing obstacles like poverty and discrimination. Health disparities, measurable differences in health outcomes between groups or the observable gaps. Health inequality, differences in health status generally, which may or may not be unjust or avoidable, but equity specifically names the unjust, avoidable ones. Human rights, which is the idea that health, or at least the conditions for health, is a right owed to all people, not a privilege. Participation and shared decision making. Patients and communities are authors, more importantly, co-authors of decisions about their care and their conditions, not passive recipients. Patient and community empowerment, building the capacity of individuals and communities to exercise control over decisions affecting their health. Access and inclusion, whether people can actually reach, afford, and be respected within the healthcare system. You might see the lab handout titled SJ in Health, Social Justice in Health. We'll be applying these definitions directly to an activity in a case in that lab, engagement and advocacy activity. Why does all of this vocabulary and definitions matter beyond the classroom? Because the presence of or absence of these constructs, equity, access, participation, empowerment, is empirically linked to life expectancy, physical and mental health outcomes, and rates of mortality and morbidity. In other words, this is not abstract theorizing. Whether a community has meaningful participation in healthcare decisions or genuine access to the system shows up in how long people live and how healthy they are while they're alive. Now we connect social justice explicitly to intersectionality. Social justice is what we call a normative concept. It's grounded in ideas about what is right, good, and moral, and it's concerned with fairness and what fairness actually requires in practice. It centers diversity, access, human rights, and participation. And it is concerned, as Dolan Riley puts it, with the fair and proper administration of laws that conform to the principle that all persons, regardless of ethnic origin, gender, possessions, race, or religion, are to be treated equally and without prejudice. The intersectional piece is critical here. A person doesn't experience race or gender or class in isolation. Someone's access to health resources is shaped by the intersection of all their identity categories simultaneously. That's why an intersectional lens is necessary, not optional, for a genuine social justice approach to health. So how do we operationalize social justice analysis? There are 3 analytical moves. First, identify and recognize the differences that exist across societal groups. Second, assess the implications of those differences. Do they translate into advantage or disadvantage? Third, examine the interrelationships among those differences. Do they compound? Do they connect to structural access to resources? This leads to a social justice activism lens, which Broom and colleagues describe as action that attempts to make a positive difference in situations where people's lives are affected by differences in race, ethnicity, class, religion, sexual orientation, and other identity markers. Notice the shift from analysis to action embedded in that definition. Social justice isn't satisfied with description. It demands intervention. In practice, where do we look for these differences? The chapter names 6 domains: education, neighborhood elements, transportation, public safety, housing, and food choices. You'll notice this list overlaps heavily with the social determinants of health we'll formalize in a few slides. That overlap is intentional. Please consult the lab handout titled SJ in Health for an applied activity tied to these 6 domains that you will do during the Engagement and Advocacy lab section. Let's turn to how social justice operates inside medical training itself. This section is especially relevant for our nursing and health sciences students and an important context for communication students studying provider-patient interaction. Medical education operates on 2 levels. The formal curriculum, what's explicitly taught, including cultural competence education, and the hidden curriculum, meaning the implicit norms, hierarchies, and values that students absorb through the culture and climate of training, regardless of what's written in the syllabus. Social justice principles in physician and clinical training have implications for both professionalism, that is, how practitioners are expected to conduct themselves, and for the broader culture of medicine. What gets valued, rewarded, and normalized? Consult the lab handout titled SJ in Medicine for an applied case that you will do on this section. Now we connect our vocabulary to lived longitudinal impact. Health inequities don't just appear at a single moment. They accumulate across the entire life course, from prenatal conditions through aging. Understanding health equity requires linking it explicitly to the social determinants of health, and again to intersectionality, since disparities compound across overlapping identity categories. Eliminating healthcare disparities isn't easy. It's not a single-step process. It requires action at the personal level, for example, the individual provider-patient relationships, at the community-based level, for example, local organizing and resource allocation, decisions that might happen in the meetings and civic council agenda descriptions, and at the communal or societal level, which is policy and systemic reform. Now, let's formally define social determinants of health for anyone encountering this term for the first time, and reframe it for those who already know it from public health coursework or Chapter 1 and Chapter 2 that we did previously in this class. SDOH are factors that determine the conditions in which people are born, grow, work, live, and age. Crucially, this is a wider set of forces and systems than individual behavior. It includes economic policies, development agendas, cultural practices, social norms, and political systems. The SDOH framework generally assumes 2 things: that everyone deserves equal rights and opportunities, and that the right to good health should be treated as a human right, not a private contingent or circumstance. When we apply a social justice lens specifically to SDOH, we're asking about income and social opportunities, housing availability, basic amenities, a healthy environment, opportunities for early childhood development, social inclusion, the absence of structural conflict, and access to health services. Notice how specific this list is. It is concrete. This is what distinguishes a social justice approach from a descriptive approach, such as that take in public health. It names what a just distribution of these conditions would actually look like. We're now ready to integrate everything. SDOH and health inequities, distributive justice, and an intersectional view of SDOH, all aimed at addressing health inequities and healthcare disparities through the fair allocation of resources. Two major policy frameworks operationalize this integration: the United Nations Sustainability Development Goals and, nationally, for a US-based practice, the Healthy People 2030 Goals, which you'll see in the next slide. If you recall, we also came across them in an engagement and advocacy application activity in one of the two earlier chapters in week 1. Distributive justice focuses specifically on the just distribution of resources for health, grounded in the human rights principles of non-discrimination and equality, and the right to a standard of living adequate for good health. In practice, distributive justice is about the availability of opportunities to be healthy and closing the health gap specifically for socially disadvantaged populations, not simply raising the average, but narrowing the gap between groups. Here is Healthy People 2030. You can find the full framework at the URL in front of you. This framework organizes SDOH into the work that goes into SDOH into 5 domains: economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and social and community context. The overarching SDOH goal of Healthy People 2030 is to create social, physical, and economic environments that promote attaining the full potential of health and well-being for all. I'll encourage our communication and health sciences and nursing students to bookmark this framework. It will reappear throughout your careers as a benchmark for population health initiatives, or if you are communicating health messages through social media networks or other organizational public relations and branding materials. Community empowerment sits at the heart of successful health promotion, disease prevention, and community health outcomes. So let's define both halves of that term carefully. A community is a group of people who share common interests, values, goals, aspirations, and identities. Importantly, a community may or may not share the same geographic space. It can be local, national, or even international. Empowerment begins at the community level, means enabling communities to gain increased control over the factors, decisions, and circumstances that shape their lives. The word enabling is doing real work here. It's pulling its load. It means that empowerment is a process of negotiation by which individuals increase their capacity to access resources, build supportive networks and partnerships, and gain a voice in political and civic affairs. It is not something done to a community. It is a capacity built with a community. And this is where communication enters directly. Communication sets the agenda, shapes beliefs, highlights issues, organizes grassroots work, and mobilizes people through social movements or organizational settings. For our communication majors in this class, This is the through line of the whole chapter. Every social justice principle we've discussed depends on communication to become action. Let's define health communication's specific role in social justice work. Health communication efforts support an individual's or community's efforts to acquire power through increased ownership and action, bringing about social change aligned with health equity goals and consistent with the social justice sensibility. 4 communication elements are central to this work: dialogue, relationship building, participatory engagement, and critical examination between all stakeholders. Notice that none of these are one directional. They all require dialogic or genuine back and forth exchange between the health communicator and the community, not top-down messaging. What does social justice activism in health actually look like in practice? It requires collective action from all sectors. Community members, guideline development groups, professional societies, clinicians, public health agencies, and community leaders. It depends on collaboration to share best practices, using data as a common reference point across sectors. And it centers on both action and communication, where communication itself involves message design and behavior change strategy, organizing efforts, and social media as a mobilization tool. This is the practical, applied face of everything we've discussed in this chapter. The lecture has highlighted that sensibility, which means foregrounding ethics, structural analysis, activist orientation, and identification with others. That becomes visible in campaigns, coalitions, and organizing work. Let's close this chapter by bringing this back to each of you. We've covered a lot of ground: a social justice sensibility, intersectionality, social justice and medical training, health equity versus disparities versus inequality, social determinants of health, distributive justice, healthy people 2030, community empowerment, and health communication activism, among much more. We'll review a lot of these in your health and engagement advocacy lab exercises. I'm looking forward to seeing what you'll all write in there. I want you, meanwhile, as you wrap out of this lecture, to sit with 2 questions before you move on to this week's lab and discussion board. What are 3 key takeaways from the social justice approach to health for you? And how will you engage them in your community? Try and think through what social justice sensibility means to you, how health disparities and health inequality are different. What might be the 5 domains of Healthy People 2030's social determinants of health? And why do you think a social justice approach requires an intersectional lens rather than examining identity categories separately? As you do all this, see if you can identify 2 ways communication functions in community empowerment, such as in agenda setting and mobilizing. So lots to chew on. I'm looking forward to your engagement and application lab activity responses. Thank you.